I am Michele Rubin. I am an advanced practice nurse in colorectal surgery at the University of Chicago. And this is my 47th year there, and it has all been in IBD starting as a new nurse, and now I'm an APN there. So very nice to have you all here. And we will get started. Here are my objectives. I'm not going to read through them here. So inflammatory bowel disease, what is it? Well, it's characterized by a chronic immune-mediated inflammation of the entire GI tract. Progressive destructive course, so there's periods where there is remission and then there's relapse. And each time from a flare into remission, it can lay down scar tissue. There are two major forms of IBD, ulcerative colitis, which is really a continuous mucosal inflammation, meaning it's only within the lining of the large intestine only. And typically it starts in the rectum and can progress fully up into the entire colon. Crohn's disease, on the other hand, is asymmetric. It's not continuous necessarily. It's a transmural inflammation, meaning going through the entire lining of the abdominal wall. And again, this can affect any part of the GI tract. It's not just in the small bowel, it's the entire GI tract. And most often it does start in the ileum and parts of the colon. So that ileocecal area is a very common area where Crohn's is first noted. Did that jump ahead on me there? Yeah. And then Crohn's disease also has three phenotypes: an inflammatory, a penetrating, which is fistulization, and stricturing, narrowing of the abdominal wall. And then there's IBD unclassified, which really means pathologically they may not be able to totally confirm, but they can suggest it either way, such as with ulcerative colitis. If it's really severe, it can go a little bit deeper than just in the mucosa, but it does not go through the entire bowel wall. And the main thing is IBD is not IBS. When I first started, they all thought they had IBS and didn't have IBD, and they were all crazy. So we've learned so much and come a long way with inflammatory bowel disease. So today there's more than 2.4 to 3.1 million cases estimated in the United States, which is roughly, like it says, 1 in 100 Americans. It's split pretty evenly between the ulcerative colitis and Crohn's. We find it more common sometimes in females, usually noted frequently between the ages of 15 to 30. Most IBD patients do not have a family history. It affects all ethnicities. And IBD patients are not Jewish patients. I'm going to tell you, when I first started at the University of Chicago on the GI floor, we had a lot of IBD patients, and a lot of them were Jewish. So that's why this is a point that we make. It is not just in the Jewish population anymore. And there's this intriguing group of first-generation Americans that are affected. So IBD represents a high healthcare cost, as you all know. Absolutely, we see this. And it represents over 25 billion annually. And the largest percentage is not in our specialist centers. It's in the non-specialized area where a lot of this is spent. They're going to the ER a lot. They get hospitalized. And so 55.8% is spent on those type of visits. So what's really important here, because we also know we want to diagnose this disease early so we can prevent the complications. So that's why educating our emergency department and primary care providers is extremely important, that we do get it diagnosed and treated early. So prevalence across health behaviors. So compared to adults without IBD patients, 21% versus 26% have formerly smoked. They sleep less than 7 hours a day, 32% versus 38%. They fall short of aerobic and muscle strengthening physical guidelines, 45% versus 50%, and have experienced serious psychological distress. And you can see that there. So there's a new population of IBD that we've been noticing more over the last few years, and that's the elderly patients. They have long-standing IBD in those who get older. It's generally a milder disease, meaning they've had it for several years and then they get older and all of a sudden things start present, and it could be a cancer in there, or all of a sudden it becomes a more severe disease. But those patients have increased risk of obviously therapy-related adverse events with their, multi-drug therapies and all of this and the morbidities that they possess. Here are the clinical features of UC and Crohn's. Obviously, again, you see that continuous inflammation, colon only, and it's superficial in the lining only. It can be a variable extent, meaning from the rectum and progresses up. It could only be in the rectum sigmoid. It could go up to the descending colon transverse or totally full extent. They do have a risk of cancer, particularly after 10 years of having the disease. The risk gets a little higher. Extraintestinal manifestations, and we know those are pretty common. The ocular stuff, skin, bones, etc., primary sclerosing and cholangitis. And then the Crohn's disease, patchy inflammation, meaning they could have some disease in the rectum and at the ileocecal area, or maybe it's in the duodenum. So it can be in different areas and patchy. Mouth to anus involvement, again, the entire GI tract. Full thickness inflammation, full thickness of the bowel wall. They can develop fistulas and stricturing disease. They also are at a risk of cancer, and they also have the extra-intestinal manifestations that can develop as well. So 3 main types based on location. Here's your rectum only, ulcerative proctitis. Here's left-sided, involves the bottom third to half of the colon. And then here is pancolitis. Most all of the colon is affected. Locations in the GI tract that are affected by Crohn's, the ileocecal disease, that is the most common area. And their symptoms are more or less the abdominal pain, diarrhea, and fever. Colonic disease, that is a little bit less. There's bloody diarrhea, weight loss, and fever. The perianal disease, you're going to see pain. Often we can see fistulas there, edematous hemorrhoids, and fissuring is what you often notice. And then the rectal vaginal fistula, 10% of women have the rectal involvement where they've got that fistula between rectum and the vagina. And then the enterovesical fistula to the bladder is recurrent UTIs, and obviously you see pneumaturia there too. That's a definite marker right away when they say they feel like they're, farting through their vagina, or they can just feel the air passing through when they urinate. Clinical features of IBD, kind of went through some of it, but more commonly with ulcerative colitis, you're going to see the diarrhea, the rectal bleeding. Most common and very common is urgency down there at the bottom. And I have that highlighted because that became was now one of the very common features that we need to ask patients when we see them. So that AGA has just put that into as definitely one of the markers of what we should be assessing at every visit. And then Crohn's disease, fevers are more common there, the abdominal pain, weight loss, signs of malnutrition, and the growth failure. Those are the most common in Crohn's disease. So urgency, the thing about it, it can still persist despite bowel symptom or endoscopy improvement. There's that persistent rectal inflammation, and the rectum doesn't stretch or store or squeeze as well. Patients are embarrassed with it. Definitely a decreased quality of life because there's that feeling of, I got to go all the time. Important to ask, this is key. When you ask about urgency, what does it mean to you, and does it disrupt your life? So urgency can come across from the patient in different ways. They could say, well, it's incomplete emptying, or I have leaks of stool, or there's pain and spasms. I have to get up at night. You know, it interferes with my work. I'm afraid to socialize. So you really have to ask the patient. They don't always know, you know, they all say something different when you ask about urgency. So those are some of the responses you get, and that probably means they have the urgency. And again, newly codified into the ACG guidelines for ulcerative colitis. And the numeric rating is like 0 to 10. 10 is the worst. So the spectrum IBD, okay, variations may exist. It's a spectrum of IBD from ulcerative colitis to Crohn. So we feel like everybody's not one or the other. I mean, some are, but they can meet in the middle. And that's where you can get sometimes that indeterminate group, because it seems like at UC, but yet there may be something there of Crohn's, and we can't really tell pathologically. So we call that the indeterminate category. Sometimes the disease initially fits one category, and then it switches to another after a few years. Like sometimes we think maybe patients have ulcerative colitis, and you know, we've done a pouch or we've done other things, and then all of a sudden things switch over to Crohn's, we find. And that's that, you know, indeterminate status sometimes. And the switch can happen years later, and they could even switch back, which is really interesting. So the immune system does not always read the book. Pathogenesis of IBD, as you can see here, we have luminal microbial antigen and adjuvants, genetic susceptibility, then on the bottom we have environmental triggers and immune system. And there in the middle is where IBD is. It can be, all four of these characteristics can be the factor. Genetic risk factors for IBD, a vast majority with genetic risk never get it. And that's important because we also thought that way in the beginning was a factor, that if there was always a family member, that is not always the case anymore. It's not terribly inheritable. So 10% of parents with Crohn's disease have a child with Crohn's disease, and only 5% of parents with UC will have a child with UC. And it is in all ethnicities. And this, I think, is very important because sometimes we have patients say, oh, I don't want to have kids. I don't want to have kids because I don't want my kids to have this disease and go through what I'm going through. But we have to remind them that it's not totally inheritable, not at all. And besides, we got a whole lot of treatments now. And if they get early identified, they can live an almost pretty normal life. So those are important things to talk about. More than 190 genes have now been discovered in IBD. And believe me, at the University of Chicago, way back when, we thought we had discovered what caused Crohn's disease because we found the NOD2 gene. Well, of course, we find out later on beyond that, oh, look at this, there's a whole bunch of genes. You have the Crohn's disease ones, the UC genes, and then look there in the middle. There's all these other common pathways. They can be leprosy, microbacterial susceptibility, other immune-mediated disease. So all those genes there are in common. The immune system, look at that. It's a balancing act. It's an imbalance between your pro and anti-inflammatory events in the system. So it's like a broken immunostat. You start out with a normal gut with controlled inflammation. Then you got some of those environmental triggers like infection or bacterial things. And then we get moderately inflamed bowel. And then some can downregulate our body, our immune system, and then we have a normal gut and controlled inflammation. But in IBD, it's a failure to downregulate, and you get the chronic uncontrolled inflammation. So there's many immune cells that are involved, and you can see, you know, all the different types of immune cells. And if you notice, all of our therapies are targeting these different immune cells in our body. Inflammatory is now a global disease. The incidence and prevalence of IBD, as you can see, before 1960, not very much. It was pretty lowly ranked, not really seeing any high ranked disease. But from 1980 through to 2006, and now, believe me, look at there, the United States, a high risk, you know, all the different portions in red, and you're seeing it in different parts of the country now. So it definitely is a global disease. So in new places and in new people, it's increasingly being seen in countries that previously had very low rates, like Asia, Central South America, Mediterranean area. And in the US, it's increasingly being seen in populations that previously had very low rates, like the African Americans, the Hispanics, and the Asians. So why is this rising around the world? Changes in the environment. Our diet, westernized diet, more fats, more processed foods, all that stuff in our foods now that mess with our microbiome. Antibiotics can trigger off. Smoking, now we know smoking in Crohn's disease is not good at all. It's very bad. And matter of fact, after patients have surgery, it is the #1 recurrence factor in Crohn's disease. Industrialization, infections, hygiene, you know, that clean environment, you know, bacteria, microbiome hypothesis, and then there's other things we're always continually finding. So what are those possible environmental triggers? Infections can do it. Antibiotics, obviously, overdoing them, smoking, diet, industrialization, stress, major stressors can also bring on a flare. NSAIDs, we know, ibuprofen, Advil, all those medications can cause ulcerations in the gut. And then there's others, again, that are still moving on. So the hygiene hypothesis, incidence of immune-mediated diseases arising due to modern hygiene, use of antibacterial soap, wipes, exposure to bacteria. Part of that, you know, can be a problem. You know how they always, we also talked about, well, if people grew up in the farm areas and they were digging in the dirt and the worms and the kids are playing around and it's not a totally antibacterial environment, is kind of good. You know, we don't want to totally remove all bacteria from our kids. They need to get exposed to things so they can develop immunity. And IBD incidence and prevalence is highest in our Western nations. Again, with the cleanliness that's overdone, or they didn't want to put their kids in, you know, daycare because they didn't want them exposed. Well, you know what? Sometimes that exposure is kind of good. And it's good that they get it when they're young versus when they're older. And then they got to miss, you know, school. Better when they're young that they develop some of these things. Early childhood exposure to pets. Being from large families is protective. So don't sterilize a child's environment. Individualized microbial landscape, 90% of cells in our body are bacterial. Most of them reside in the gut. We're born germ-free. Microbes that live in our gut come from the environment, our infant diet, our hygiene, medications, breastfed versus formula fed. The breastfed, your immunity is passing on to the child. Genetic influence, identical twins have similar bacterial communities. Diet and the microbiome, large differences in the microbiome between regions and between rural and urban areas. High-fat diets increase the proteobacteria and Firmicutes and decrease the bacteroides that is the good bacteria. And you can see the United States, look what we have over there versus the European countries that are more Mediterranean diet. Individualized dietary approach, though, it's not a one-size-fits-all. Factors to consider are location of disease. Where is it? Small bowel, large bowel, stricturing or history of obstructions. You know that, you got to watch your diet because so you don't cause an obstruction. So sometimes those low residue diets are better. A fistulizing diet, constipation versus diarrhea. When they're in a flare, their diet needs to be maybe more the low residue, less spicy versus when they're in remission, they can go back to eating some of those things. And then there's that disordered eating that patients develop. And we see this sometimes commonly, at least I see it with patients who have had recurrent obstructions and stricturing, and they stay away from high residue foods and your vegetables, raw vegetables and all that kind of stuff. And then when they have surgery, we've removed that obstruction. They can't get over the fact they still want to continue doing that low residue diet because they can't get it out of their head. Like, this is my whole life. It's been a problem. And so it's always very important to discuss the disordered eating syndrome that can occur and get them on the right path if that's not there anymore. Active disease diet, increased energy needs, focus on smaller, more frequent meals, limit foods that may worsen symptoms, your high fiber foods, your high fat fried foods. Caffeine causes a diarrhea, alcohol, carbonation, gas there. Sugar alcohol, another thing causing diarrhea, like some of your seed oils too. And then lactose, if they have a lactose intolerance. Those are all components that they need to watch out for. Your remission diet, Mediterranean diet is often recommended. High fiber is tolerated. Olive oil, limit and avoid red and processed meats. Moderate intake of poultry, fish, dairy, wine. Limit processed foods and additives. High fiber diet is protective for patients with IBD. You want to avoid overly restrictive diets because then they don't get some of the nutrients that they really need. Like, they're just separating out this whole section of nutrients that they need. You want to optimize their nutritional intake as they tolerate it and retry foods that were not tolerated during a flare. They may be able to now eat them, obviously, or like after they have surgery is another thing. Come on, we can get back into maybe eating a more normal diet. And here's the impact of lifestyle factors. You see the stress over there. We know stress definitely is a factor and increases flare. Having IBD is also a perceived stress. So stress management is very important. A physical activity decreases a flare, improves surgical outcomes. Obesity can increase a flare. Also failure of biologics. Often you need a much higher dose perhaps there, but they don't work as well, and obviously obesity can increase surgical complications. The other thing is cannabis can decrease symptoms, but it can increase substance dependence and things like that. Also, we know it does not work on inflammation. They may feel better, but it doesn't actually do anything for the inflammation. Sleep there, the other thing that has a bidirectional relationship. In IBD, they have increased sleep disturbance during the night, maybe having to get up, go to the bathroom. Also, increased fatigue in these IBD patients as well. Alcohol, inconsistent as to whether it helps or not, and it doesn't really have a big effect on complications or things. Smoking, increased complications, we all know, in Crohn's disease. And if they're going to have surgery, obviously we want them to back off of smoking for a few weeks or more. We want them to actually quit. And that's really what we want them to do. But it doesn't, it may decrease flares in ulcerative colitis, which is a real strange sort of thing. It's not good in Crohn's, but in UC, it may decrease it, because sometimes what we found that patients may develop UC after they've stopped smoking. And obviously, we don't want people to smoke, so smoking is a no-no either way. Psychological comorbidities. So 25.2% of patients with IBD experience symptoms of depression. 32.1% of patients with IBD experience symptoms of anxiety. 32% with IBD experience symptoms of post-traumatic stress due to past medical trauma. Could be something they've experienced, a bad experience in the ER or in the hospital with surgery, whatever, and they develop that post-traumatic stress syndrome. I even see this in patients who come to see you in clinic. Sometimes you're going to notice their blood pressure's up. They kind of get, oh my God, or they're driving to the parking lot and they're just reminiscing all that past of coming here when they were so sick. So that is a very common thing to see there. Disease-specific quality of life concerns, pain and bowel urgency, 30% in UC, 60% in Crohn's disease. Experience the abdominal pain and remission even. Sleep disturbance and fatigue, 56% of patients experience poor sleep. Here's your disordered eating, or it's called APRN. which is 16% of patients with inactive disease meet criteria for that. They, like I said before, they still have that eating avoidance disorder. Social stigma, 84% of patients disease related stigma. Socially, obviously we know that. They don't want to go out and eat. They stay at home. They're afraid of the bowel movements. You know, they just socially can't interact with other people. They're having too many issues in pain or whatever. And then how does it impact relationships? Obviously, sexual dysfunction can be 3 times higher in the IBD patients. So definitely these are all important quality of life concerns. So mental health, psychosocial and intimacy issues, my mantra is just ask, because they aren't going to always tell you. So you need to open that door to discussion. Are you doing the things you like to do in your life? Are you spending time socializing with friends or your family or your grandkids? Do you sometimes feel depressed or anxious? Do you feel your symptoms control your life? Are you having issues with intimacy? These are all really important questions to ask patients. And here shows a little bit relationship between the environmental factors and development of Crohn's disease. And you see, as you see that dark, really dark blue, smoking and stress elevate the risk. In there, the linoleic acid is in UC, and both Crohn's disease and UC is the purple. The GI infections, OC use, high carbs, fats, urban population, antibiotics. That goes either with the Crohn's disease or the UC. And then what lowers risk? Vitamin D, high fiber, H. pylori, and Helmness are for both UC and Crohn's disease. And smoking there, again, you see the UC, it has somewhat of, it's got a lower risk there. But again, we don't want people smoking, so we're not telling them to smoke. Key similarities between them, both are part of a spectrum of inflammatory bowel disease between UC to Crohn's. Both involve the immune system attacking part of the GI tract. Both require control of the immune system with medications and often long-term. And both can usually be controlled with regular medical visits and monitoring. So what do we tell our patients to avoid flares? Strong recommendations: avoid NSAIDs in both, quit smoking in Crohn's disease, adhere to prescribed medications. Modest recommendation: maintain vitamin D levels, exercise. Common sense recommendations: again, exercise, sleep, reduce stress in your life, meet with the dietitian or the nutritionist. That's very important to help them understand. You know, they feel like I got to be in a low residue diet. Oh my God, I can't have any fruits or vegetables or what. No, they can talk about what are non-soluble fiber foods and things like that. And then, very important, screen for depression and anxiety. That is very important. They have a lot of stress in their life. And again, stress is a huge factor. So we need to definitely talk to them about that. But remember, many IBD patients have normal or near normal lives. Most can work, go to school, enjoy social events. Most can start families and extended families, and most can live a normal lifespan. Those are all very good comments and issues to talk about with your patients. They have to remember these issues. They can have a somewhat normal life. It's very possible.